Sure. Okay, so good evening, everyone. This is all very wonderful. So today we have Dr. Ooi-Thye Chong talking about acupuncture for pelvic pain in women. She's got a doctorate from the University of Edinburgh, and you're still working at Edinburgh, I think, aren't you,
Yes,
Ooi-Thye?
I am indeed.
Yeah. So lots of very interesting history, which I've sent to people so they can read it. And I won't hold up the program, but so Ooi-Thye is going to talk about acupuncture for chronic pelvic pain, which is a massive problem, um, and seen through the eyes of a Jean Gebser, a French philosopher. Am I right?
Swiss.
Swiss, right? Okay. So over to you, Ooi-Thye.
Thank you. So, thank you for having me, Maureen, and thank you for everybody for attending my talk. So, let me see if I can. Oh, how come I cannot move the next slide? Oh,
Okay.
that is very strange. Here we
Did
go.
it. Did it.
So, this is a 30-minute presentation, and it's almost like a lifetime of my work. And I feel that it's impossible to cover everything in 30 minutes. However, I will try my very best. Can you hear me, everybody?
Yep.
Yep.
So I will try my very best to cover what I did in acupuncture for women with chronic pelvic pain. And also, I stumbled upon John Gebser's theory about 5 or 6 years ago. And to me, that was one of the most important things, theory that I have come across that applies to my work. So his work is immensely complicated. And what I've done is extrapolated from his theory into the kind of work that I'm doing. So without much ado, I don't understand why it's so difficult to. Oh, here you are. It's jump. Okay, so just to give you a very quick background of who I am, I lived in New York City for about 24 years, and in a significant part of those years, I was the head of integrative medicine program in New York University Langone Cancer Center. I mean, they've changed their name so many times depending on who is the biggest contributor to their finances. And so, what do I do there? We actually have a center. I started the whole center, and we use the best of biomedicine and therapies like acupuncture, Reiki, yoga, herbal medicine, nutrition, to deliver that to our patients. So the aim is not to cure cancer, but the aim is really to deal with the side effects of cancer treatments with services such as acupuncture for nausea and pain. Here you see I put pain, physical and psycho-emotional pain. Many people really do not know that a combination of acupuncture and other therapies actually deal very effectively with psycho-emotional pain. I also use Chinese herbal medicine. I have my own formula for dealing with diarrhea and mucositis with great effect, I have to say. And so does Reiki practitioners who come in. They deal with our patients when they have great anxiety, panic attacks, and kind of a lot of emotional angst. A lot of patients also use Chinese dietary approach because they really like the idea of the yin yang approach, hot and cold. And the other therapy that we offer is massage, and this is offered during chemotherapy. The massage therapists actually come into the chemo room to give patients reflexology of the foot and also head and shoulder rub. And most patients find that extremely relaxing. I mean, what is there not to like, right? Just think about the power of touch. Fast forward many years, my husband and my late husband and I were recruited to Edinburgh about 12 years ago. And I treated many patients with chronic pelvic pain within a multidisciplinary chronic pelvic pain team. Uh, so about 60 to 70% of the women with chronic pelvic pain actually have endometriosis. And as you all know, pain is the key feature of endometriosis, quite apart from anxiety, depression, and sleep disturbances. Unfortunately, most women who referred to me really like I'm uh, the end bit of the services when they no longer respond to pain medications, or they really couldn't withstand the serious side effects of, say, opioids or other pain medications. How do I do this? I use a multifaceted approach to chronic pelvic pain. Unfortunately, I think the top is cut off. Am I right?
Well, we can see a multifaceted approach to CPP
Okay.
at the top.
So I use an acupuncture style called the balanced method acupuncture. In my screen, that is blocked off by you are screen sharing, but I hope you can see it. And with this balanced method, I basically use it to treat physical pain and is outlined in chapter 3 and 4 of my book, which I will talk about a little bit later. And the other style of acupuncture that I use is known as the 5-element style acupuncture. I use this very effectively for psycho-emotional distress, depression, anxiety, fatigue, a lot of the stuff that goes with women with chronic pelvic pain. And I've outlined that in chapter 6 of my book. And of course, one of the key tools that I use are non-needling tools like breath work, inner sensing, journaling, imagery, and the things that I've listed here. And again, this is outlined in chapter 9. Finally, I practice a kind of healing known as alchemical healing. It's really in alchemy, people transform lead into gold. So we applied that term, which is not a new term in Chinese medicine. It's been in Chinese medicine as old as Chinese medicine. We work with anxiety, depression, panic attack, and use different approaches to turn that into something that patients could use. For example, if they have fear, we have a concept called turning fear into wisdom. So these are very powerful, and I've outlined that in chapter 7 of my book. So what is the Meridian Balance Method acupuncture? This method is fantastic. We never really needle the painful areas. We always find a distal point or distal points to affect the painful area. And it's made popular by Dr. Richard Tan, who died about 5 years ago. He was a very funny guy, quite politically incorrect, but extremely good teacher. So what we do is we get the patient to tell us where the pain is. What I'm doing is identify the sick meridian. And then I use the healthy meridian. You have to know all your meridian system, of course, to balance the sick meridian. And then find the usher points on the healthy meridians for treatment, either using a mirror and image method. And this is outlined in chapter 3 and 4. So I'm not going to go through all that because I can spend an hour talking about that, but I won't. I'll just move on. So effects of the balance method acupuncture, the pain relief is almost always immediate. When I first heard about that, I thought, I don't believe it, until I actually started treating patients. And when I did that, I kind of surprised myself. I thought, oh no, I don't believe this. This must be a placebo effect. Until started treating more and more patients, I realized that that was true, that it really is a physical effect where the pain goes away almost immediately. So it's very good for skeletal muscular pain, acute pain, and I've treated patients with surgical pain at St. Vincent's Comprehensive Cancer Center, where I also started an integrative medicine program
Hi,
in
Peter.
New York. Hello. So, of course, it's good for
Yes,
chronic
yes.
pain,
You should have
otherwise
the
I
link.
wouldn't be.
I'll send the link to everyone. Oh, okay. Right, I'll have a
Is it
yes,
okay?
find it. Right, I'll just I'll come out. Yeah, it's fine. Right, okay, yeah. Stay with
Okay.
it. Yeah,
Okay.
okay, yeah, okay, bye.
So here's some of the patients, what patients say about the treatment of acupuncture. I found it a godsend. It took my pain away for a day or two after the treatment, which I hadn't had in over 6 years. Remember, these patients who come to me have had pain for a long, long time, and they no longer respond to pain medications anymore. And it made a big difference to their lives. Another patient said, I felt I had more energy and I slept better. I mean, what is there not to like, right, if you're in pain? So what is my professional goal? My professional goal, having worked with so many patients in the cancer center and so many patients at the chronic pelvic pain team, I realized there's a lot of suffering. So it created a deep desire in me to try and help women and patients who are suffering through different approaches mentioned earlier, that patients have found helpful, and in my experience at least had led to a different experience of their pain, a better quality of life. And when I use alchemical healing, a transformational state where we need to work. I mean, not everybody wants to work, do inner work, but when they do, the result is amazing. It takes a lot of work, takes a lot of energy on my part as well as the patient, but that is work at the soul level. So, how do I achieve my professional goal? So, I started thinking about doing my PhD, which I did. I was so impressed with the Meridian balance method that I used that to do as in my thesis. I completed after my PhD. I completed my book for chronic pelvic pain because I felt that I really had something important to say. I didn't write this book out of vanity or want to make money, because really this book is a, I'm sure if anybody has written any book will realize that writing a book is a labor of love. And I just felt that I had something important to say. And another way of achieving my professional goal is to plant what we call spirit seeds. For example, I'm in the progress of starting a website called Create Nourishing Life, Nurturing Self. And it's going to be like a salon, and people come together and we can discuss how to go about nourishing life and nurturing yourself. And the other thing I can do is present talks, which what I'm doing now, and then I have one coming up in June, and I'm doing workshops in February um, in Edinburgh, and in December in Kunming, China. So I'm hoping that at least I will make a little bit of difference to women who, or to patients, doesn't have to be women who are, I just happen to be working with women, but patients who suffer. And really, I think there's a lot of work to be done here. As Maureen said, chronic pelvic pain is a huge problem. So, when I wrote this book, my overarching aim is to help professionals who are interested in treating women with chronic pelvic pain, as well as helping women suffering from chronic pelvic pain. And this book is really based on many years of my clinical experience. And as I say, it took me about 2.5 years to write this book, and another year, 9 months before the publisher was able to put it on the market. So eventually in 2024, this came out. Yes, September 2024. No, May 2024 came out. So I'm very proud of this book. So now I'd like to talk a little bit about my mixed methods pilot study that I did for my PhD thesis using the Meridian balance method, and I added electrostimulation to it based on my clinical experience that if I add electrostimulation to the acupuncture, the effect actually lasts much longer. And there are actually many studies to show that if you use 2 hertz alternating with 100 hertz, you end up with 4 endogenous opioids. And that really helped with the pain. But I'm not going to talk about those studies. Anybody interested, I can send them the references. So because this is only a pilot study, I recruited 30 women and randomized them into 3 groups. The balance method electroacupuncture, so the acupuncture plus traditional Chinese medicine health consult. This health consult actually is a way of looking at health and wellness through the lens of Chinese medicine. And at the end of it, the patients would go away with some advice as to what to do with their health or the most pressing health concerns. So they come from acupuncture and then the health consult. Very important. The first treatment is much longer than subsequent treatment because we have already known the patient. And the second group is traditional Chinese medicine health consult only. So every week we would meet and we would talk about their health, the most pressing health concerns. How has the health consult helped them the previous week and what new problems have come up again. And the third group is the National Health Service standard care. So the effects of the intervention was measured by validated pain and physical and emotional functioning questions at 0, 4, 8, and 12 weeks. So the qualitative part of it, I did a semi-structured interviews and focus group discussions to explore participants' experience of the study. It was very interesting to do the semi-structured interviews as well as the focus group because it gives me some measure of understanding how well the quantitative result match up with the qualitative result. So here is, in a way, it's not unexpected that these results come out. The balanced method electroacupuncture group with the health consult have, when compared to the other 2 groups, which is the TCM health consult and the NHS standard group, this acupuncture group had a higher proportion of patients who achieved clinical significance in pain, sleep interference, and daily life interference scores. They have less pain, less anxiety, and less depression. But when we looked at the compared all the different results, the therapeutic benefits gained was highest in the Meridian's balanced acupuncture treatment group, followed by the TCM-HC group, and I'm afraid to say that the NHS-SC group reported very little benefits. So here's the analysis of the result, which some of it is blocked by the picture here. So the balance method electroacupuncture, there's a whole person effects. There's pain reduction. Almost all participants reported a reduction in pain together with a better sleep, better energy. But I guess if you're sleeping better, maybe you have better energy. And if you feel sleeping better and have higher energy, and feeling much better, then your overall well-being is better and you're coping much better. So on the whole, it's very optimistic for the balanced electroacupuncture group. The TCMHC is also have a pain reduction, whole person effects, but the number of patients, volunteers, or participants who reported pain reduction was less than those in the balance method group. Similarly with the sleep and the well-being. So you can see the balance method acupuncture did better than the TCMHC, and NHS standard care came out, I guess, not so well. There was a lot of frustrations expressed at the ineffectiveness of pain medications. Almost everyone, without fail, reported a huge dislike for the side effects of medications. They felt woozy, they couldn't go to work. If they were on opioids, they felt they constipated, and then they started to have, if they become a little bit not addicted, what's the word I'm looking for? Habituated to it, they feel that they need the opioids. And then they vented frustrations at seeing different consultants at every clinical consultation. What it meant to the patient was they have to repeat themselves every time they see a doctor, because every consultant was different at almost every clinical consultation. And then another frustration they vented was it seemed like none of the consultants that they talked with, or the nurses, seem to know what's happened in the previous consult. So a perceived lack of communications. So I look at this result and I wonder now, why is that? Shouldn't National Health Service standard care be doing equally well as TCMHC or the acupuncture the participants received? I thought about it and I thought about it. I come up with this hypothesis that the clinical outcomes in pain management fundamentally depends on a therapeutic relationship. I'm sure many of you here would agree with me. A therapeutic relationship between the patients and the healthcare providers based on compassion, deep listening, kindness is so important. I'm sure you nobody would disagree with me with that. And I look at the result and I thought, well, how obviously with a combination of therapies integrated into biomedicine, it has helped the patient. And my hypothesis derived from the findings of the result of my PhD thesis, as well as the positive effects of my many years of clinical experience. So I thought to myself, how do I go about changing things to achieve better clinical outcomes? So for many years, I felt really very frustrated that I couldn't explain why therapies that I provided at the NYU Cancer Institute and the St. Vincent's Comprehensive Cancer Center and Edinburgh Chronic Pelvic Pain team, I could not explain why these therapies are therapeutic. I just felt that there was a great disconnection between my clinical experience, which is not 2 years, but really spent over almost my whole lifetime, and the establishment views. I thought, how do I get this disconnection to narrow, and how do I close this gap? Because I think it's very important to do that, and this is like my mission. So I felt so frustrated for so many years until I came across Gebser's theory of structure of consciousness. So it was like a light bulb moment for me. I learned about this from a 1 year course with Laurie Desha, who was my teacher in in New York. Well, now we've been friends for a long time, and we did a 1 year course called Awakening Consciousness for Healing, and this is really was all about Jean Gebser's theory, how we can extrapolate what his theories into Chinese medicine, and where the intersection was between his theory and Chinese medicine's theory. So Gebser was a Swiss philosopher, a poet, and a linguist. And his work is so immensely complicated. Takes forever for me to understand, but I grasp some of it. I'm not saying that I understand everything, but enough. So the five structure, this is a very important slide. So you need to take note now. So the mental structure, this is our rational self, our intellect, and we have an ego, a point of view, an ability to solve complex problems. And we use this every day, not only in healthcare or academic situations, we use this every day in our life. And so everybody is very familiar with the mental structure. And this mental structure, the rational ability to solve complex problems, has been the foundation of modern Western science and medicine. It dominates all the other four structures, I think, to their detriment and therefore to our detriment. So moving on now to the archaic structure, that is our an undifferentiated self, is like the fetus in the uterine state, our original state. I guess talking about in psychological terms, it would be equivalent to our unconscious. And the clinical potency based on our Chinese medicine is its ability to heal trauma. You can't heal trauma with the mental structure. That's what we believe. And we can access the archaic structure via acupuncture, chanting, meditation, breath work, and many other things. I just named a few. And I've bolded that into green because those are really a very quick way and an effective way of accessing the archaic structure. So next comes the magical structure. And how often have we talked about go with your gut feeling? Now, when we do that, we are talking about our magical structure. This is a time where, as our consciousness evolve, there's no words yet. It's just using sounds and movements and dance to understand the world. So it's very much connecting with the animal body. And what is its clinical potency? Because at this stage in our consciousness evolution, we have not learned to speak. So we listen with our body. What is our body telling us? And when we go into the treatment room, how important it is to remember to set an intention, to deeply listen to our patients, deeply listen to ourselves, what is going on inside me. And also, when you go into the treatment room with that intention, I think it makes a big difference. You can access the magical structure through acupuncture, using the 5 elements that I talked about, and affirmation. So there are many ways of doing that. Here are only some examples. Of course, the next one, moving on, is the mythical structure. This is very much centered on the heart, not so much on the gut. So, what is my life's myth? And myth is very important to us. And it's a very hard, its clinical potency lies in heart-centered feeling and knowing. Also of great importance in the treatment room. When we are centered in our heart, we can connect heart to heart with the patient, and we can allow time for patients to tell the story. So when patients tell the story in a positive way, it affects them in a positive manner, because we are the story we tell ourselves. So when we use all the 4 structure, mental, archaic, magical, mythical structure, all together, we then enter into the integral structure. And this is somewhere that we all should get into. And that is, in a very, very brief way, Gebser's 5 level of consciousness. So what is the problem with using the mental structure alone? As you can see, Western biomedicine primary focus is on the body, and a huge emphasis on evidence-based medicine. This is well and good. I have nothing against evidence-based medicine, nothing against the body-based medicine. However, when it's totally focused on that, or significant amount of energy is focused on the body and evidence-based medicine, the result is you exclude other therapies such as acupuncture, massage, Reiki, all the therapies that I talked about. And these are considered, at least by most, as not evidence-based, cannot be logically explained. And what it means is that we are excluding the magical, mythical, and archaic structures of our consciousness. And I think that is a very sad state of affair. So what happened is that when we allow the mental structure to dominate everything we do, we end up with a very narrow, sterile, and unsatisfactory definition of health based largely on the lack of disease. So when you have this definition of health, healthcare services follow suit. So a lot of healthcare services that we have now, I think many of you would agree, largely do not adequately serve our patients or healthcare professionals. I'm not blaming it only on the mental structure. I'm sure there are lots of other problems related to the healthcare. However, I think we will move towards a better solution. And we need a more inclusive and meaningful approach to deal with our increasingly complex and multi-dimensional healthcare needs. I think that is very important, because our health problems is not just physically based. There's so many psycho-emotional, spiritual issues related to our health. I was at a art exhibition in Leith this afternoon, and a young man, he must be about 25, he was exhibiting all his photos taken in the Highlands, and the story was so sad. He went through being suicidal, depressed, panic attack, and it was so good to see him kind of reviving. And through being in contact with nature. And so he's spending a lot of time now raising money to, I guess, try and include more young people to be in contact with other stuff in nature, nature based. So how do we tap into the archaic structure? In Chinese medicine, it is related to the water element. This relates to the five elements: water, wood, fire, earth, and metal. And within the water element, we believe it contains very powerful energy that is very healing if you can tap into it. It's very effective for patients who suffer from traumatic events, fear, or hopelessness. And again, we can access that by acupuncture, Reiki, chanting, yoga, breathwork with imagery. Being present with patients, creating a heart-to-heart connection with patients is one of the ways to connect, to access the energy of the archaic structure. So next, I talk about the magical structure. Remember, it is all about the connecting with the animal body and the gut feeling. Follow your gut feeling. I thought that was a really great way to explain the magical structure. So we need to listen to our body. What is it telling us? What is it? What are the sensations? And what needs to be heard, importantly? What is my body telling me? What needs to be heard? This body-knowing connection is very visceral. It's in the gut. And that is a time when our magical consciousness doesn't involve words. And it's very important for the healing work of clinicians and patients when you can connect with that patient on a heart-to-heart level. So when we as clinicians go in to treat patients, very important to set an intention. Very important to know what's going on inside you. And we can do this also using five-element acupuncture treatment for releasing emotional, spiritual blocks. So finally, the mythical. So centers on the myths we create for ourselves. In fact, the stories that patients tell us are the stories we tell ourselves as to who we are. And this myth is very important in the clinical encounter to allow patients, to make room for patients to talk about their stories. And I think it's very important to be heard and to be listened to. And that is where the connection is. And Carl Jung thinks that this kind of myth is an essential part of our psychic. So this is more ways of listening, tapping into our mythical structure. How am I doing for time, Maureen? So when we use the mental, archaic, magical, mythical structures all the time, we arrive at the integral structure. And this is where we want to aim at. It is a dynamically harmonized whole. And when we have that, I think it will broaden our, not only just our healthcare view, but I think it will broaden our world view. And so that we are not dominated by the mental structure alone.
Yeah.
So
Okay. This is all good stuff. Have you got, sorry, I don't want to hurry you because it's all really interesting.
okay. I'm coming to an end now.
All right.
This is
Yeah.
just few guidelines that I think would
Okay.
add to the
Yeah, no,
flexibilities.
completely fine.
Yeah. So how to recommend therapies that are safe, reasonably acceptable, and how to discourage people using therapies that are serious risk. So I'm just inviting audience here to reimagine an alternate world where healthcare services can adopt the Jean Gebser's structure of consciousness to conceive and to deliver a more inclusive healthcare service. And to kind of rethink about hardcore evidence-based therapies, that other therapies that don't have RCT to prove that it works actually may just work as well. I think it'll work based on my clinical experience, but many of them don't have RCT to show that. So, concluding thoughts, I would argue that using Gebser's structure of consciousness will help us understand the different therapies that are not evidence-based. It might help to change healthcare policies, and it could be very healing for patients and healthcare practitioners, because when you connect heart to heart with your patients, you know you have made a difference to your patients' lives. So I would just want to make an important note that I'm not against evidence-based medicine. I just have difficulty coming to terms with its hegemony to the exclusion of so many non-evidence-based therapies, and thus our archaic, magical, and mythical structures. Thank you for your attention.
Brilliant. So fascinating. Thank you very much. So, right, so open to the group. So if you stop share, please, Ooi-Thye.
Okay.
Now we get everybody on the screen. Lovely. So, anybody want to ask a question or make a comment or observation?
Or disagree violently with me?
Yeah, there might be one of them. Yeah.
Oh, I'm sure. I realize I'm sticking my neck out.
You are.
But you can't reach me. I'm so far away.
Oh, good. You're safe. Ernie's got his hand up.
Okay. So my findings were pretty much similar to yours. I did my research in China, and I found that 1 week, it was for garden variety back pain. 1 week and 6 months later, they had clinically significant improvement on a variety of outcome domains, including pain. That is, their pain was not only improved statistically, but it was meaningful to the patients, including emotional well-being, all sorts of things, disability. Now, here's my question. I think that's evidence-based.
Yeah.
Just because you say, you say that there's some sort of an inconsistency between the evidence-based healings and guidelines. I don't know why acupuncture is not in guidelines, but I think that if it's from the patient's point of view, and these are all when you're dealing with pain, it's basically from the patient's point of view, if it's clinically significant, even at 6 months, why is that not evidence-based?
Yeah, I ask myself those questions. When I go to conferences, they say, everybody says to me, look at me and say, well, what you do is not evidence-based.
Yeah.
I stood up and gave a talk at St. Vincent's Comprehensive Cancer Center. They say, what you do is not evidence-based. So I say, look, I'm here not to cure cancer. I'm here to I'm on your side. I'm on the doctor's side. I'm on the patient's side. I'm here to help the patients deal with the ramifications of the side effects of chemotherapy, as well as the ramifications for cancer diagnosis. And these are really big deal. And if you have practitioners like myself who is willing to do that, what is there to get upset about? Come on.
Well, I know they do get upset.
No, I'm not talking about you. I'm talking about when I stood up at St. Vincent's Comprehensive Cancer Center. They say, oh, this is not evidence-based. So I get that thrown in my face a lot. After a while, you kind of get a little bit fed up.
So they're not looking at the evidence.
MD types do get upset because it's not the world view, this acupuncture. And but I think for the patients, it's important to say it is, and to insist on the point of view, because again, I found it's, again, I've just done my research in China. I don't know what it is, the outcome, if I would get the same results in the West.
Well,
But
I have to say that from this, I've been in this field for over 20 odd years, uh, just showing my age. When I first started, there were actually very few studies about acupuncture. Um, but there are more and more now. There are plenty. Now, I think acupuncture is very evidence-based. But things like Reiki, uh, I mean, I am a herbalist. You try and convince oncologists that it's okay to give patients. I steep some herbs in alcohol, and it's for mucositis. It works like magic. Now, why this is so effective? Why are patients not allowed to use that? So my frustration comes from my clinical experience. There's a big gap, disconnect between establishment view and my clinical experience. But I agree with Ernie that some of the therapies I talk about are evidence-based.
and
Okay.
also we have to be the advocates for the patients. So if the patients are feeling, again, I'm mainly basing this on China, but after all, most of the world's population does not come from affluent Western countries. We have to be advocate for the patients
Yeah.
Yeah.
all over the world. Um, and
Okay.
okay,
Uh,
she said okay.
I think Kate wanted to contribute. You have to unmute, Kate.
Thank
Where's
you.
Kate?
Hello.
Oh,
Hi.
hi.
Hi. I'm just writing up my PhD now. And I'm looking at mind-body interventions for breathlessness in palliative care. And so I'm really kind of with you on this whole thing. And I put into the chat. So I'm based in a medical school, so I kind of have to walk the walk, because that's where my funding is. So there's just the thing I put in the chat is about this concept of interoception. And I don't know what you or anyone else thinks about this, but this seems to me to be an acceptable point for us to talk around when we're talking about feeling into the body, gut instincts. That's, that sense of feeling one's own body from the inside out is that idea of interoception. And there's also some really interesting research out there on heartfulness and mindfulness and interoception. And it's just that it seems from my research, because one of the things I'm looking at is what is acceptable language where we can all meet, right? So where can we meet that everybody's happy? Where the patient understands what you're talking about, where I understand what I'm doing, where I can express it to them and to the medical community, and everyone's happy. Do you see what I mean? So that's my first point. The second thing is that I think there's a lot of post-colonial stuff here. So I say this as a white English person, we went all over the world saying our religions and our medicine and our way of doing things was the right way, and people bought it and they used it and they were, they took it on. And this has gone on, so now there is this sort of imbalance. So these things from other cultures are not accepted because of so these are sort of deep historical biases that, you have to see them for what they are. And it's really interesting because I've been interviewing people about this, and it really touches people's nerves because evidence-based medicine, Western medicine, the post-Enlightenment philosophy, it's so powerful. So anyway, sorry, I could go on.
I think that inner sensing is very, very important. I use it all the time with my patients. I actually can immediately feel what they're feeling, and this is actually there's a lot of work done by a psychologist called Eugene Gendlin, and he started that. I don't think he called it inner sensing. This is something that we in alchemical healing started to call that inner sensing because it makes a lot more sense, and it taps into Chinese medicine be the heart being the center of the queen of emotions. If anger or compassion doesn't go through the heart, it's fake. So you try and show compassion to your patient and it doesn't come from the heart, the patients can tell that.
Yeah. Absolutely. Thank you,
But
Sarah.
I'm really very interested to find out what the audience thought about the Gebser structure of consciousness. I thought that this might just be, in answer to Kate's question, just be the common language that Western medicine. I actually fall under the School of Medicine in Edinburgh, so I also have to walk the walk.
Yeah.
So I'm really curious to find out what the audience think about the use of Gebser's structure of consciousness to try and explain away how different therapies touch our different levels of consciousness. Surely that is a lot more acceptable way of explaining things, at least to me.
Yeah, no,
I mean,
it's interesting.
thank you so much, Ooi, because I think you know, we've met up in Rydal Hall and obviously hit it off quite rapidly. But I mean, I think there are huge parallels, and I too, as an oncologist, struggle with being a slight maverick in terms of my interest in clinical hypnosis, and trying to get acceptance, you know, on the wider level for another extremely well evidence-based intervention, which you know, has so many echoes within what you've been talking about, in terms of that therapeutic relationship that is absolutely instrumental to being able to effect change on a deeper level. And within hypnotic communication, it's all about trying to empower people, understand where their fears are, and that existential you know, issue is often a very big driver in an oncology setting, you know. And I just wanted to explore with you a little bit more with regard to that fascinating work you did on your PhD in terms of these patients dealing with deep pain, chronic pain, which obviously the instruments of change in the NHS were not affecting, despite, I'm sure, having some very well motivated clinicians doing their best, altering medications and things. But within the framework that you were seeing patients, comparatively, how much time were you able to spend with them comparative to those consults the NHS imposed? And how much, you know, as you alluded, you know, the change in clinicians, everybody's, you know, having to start over under a time pressure, you know. So I think it really heralds to this understanding of what the placebo effect perhaps brings, because the placebo effect is an incredibly strong effect that we don't utilize. And
I think you just hit it right on. I think it's a real shame not to harness the power of the placebo effect. And when I was studying with Jeffrey Ewan, he talked about burning moxa to warm the inside of the patients, or patients who feel cold. And he said, you just don't do it like mechanically. You do it with care, with attention to details, to attention to the patient, with some love and kindness. Even if your moxa doesn't work, the patients walk away, his inside has already been warmed. And I thought, how smart, how clever is that? So why aren't we using that? And that is not placebo. That is a patient, a practitioner or doctor relationship. That is so fundamental to the healing.
I agree. And I think the open placebo studies have very much sort of revisited the philosophy or the hypothesis of what the placebo is. It's actually the effect of care.
Yes.
And that care of one person for another is actually what's making the healing happen, the magic, you know?
Yes.
But you know, we have a real problem with the word magic in Western medicine
Yeah.
because we're evidence-based and it has to be measurable, but there are lots of things that aren't very measurable but very real. You know, and I think that you know, there are some fascinating things within the sort of the mind consciousness realm, if you choose to look there, that philosophic phenomenon, which is all about existential, you know, continuum, I suppose, that perhaps, you know, cuts to the quick of some of these issues that are all based in fear and anxiety, and how that care phenomena actually removes that, and it's empowering people to be able to use resources, the breathing, the breath work,
Yes.
in alliance with, you know, I'm not saying that acupuncture doesn't work, don't take that at all. I very much think all of these things work, but in a very, you know, sometimes difficult to pin down way. But it was really interesting what you were saying about the measurability of the endorphins and, you know, opiate responses for your patients, and cutting down, you know, on their doses perhaps being helpful
Yes.
measures.
And the researcher who's done a lot of work on electroacupuncture is someone called Han Ji-sing. I can send you his name, and he's done a lot of work, and very interesting work on 2 hertz alternating with 100 hertz. If you do 2 and 100, it gives very different result,
Oh, very interesting.
because the body sees that as 102 rather than 2 alternating with 100.
Okay. Brilliant. Thank you. And thanks, Sarah. So Jens, you wanted to come
Yes.
aboard?
Yes, I'm speaking as a street level bureaucrat who does a lot of healing as part of engaging with the patients as a GP. And without healing or connecting from the heart and listening, nothing would work. If I would be just an administrator referring to services, most people don't even make it to the services. So we are doing a lot of holding work. But I also made it to higher echelons in the scientific bureaucratic realm, to NICE guidance, as a member of the NICE guidance committee for chronic pain. And these people are not stupid. So I would call it not evidence-based, I would call it research-informed. And everybody there had a fairly open mind, making sure that all the research is vetted according to all the quality criteria, and not much stayed there. So opioids gone, gabapentins gone, all the orthodox established treatments for chronic pain, suffering, idioms of distress are on clay feet. That was very difficult for the experts in the field. They didn't like it and kicked up a bit stink. What remained was all of what you say, emotional connection, whatever you want to say. NICE said, I don't care what you say. I want to strip it of its ideologies, call it good communication, good bedside manners. And that's very, very difficult to establish. You need to establish a relationship. You need to ensure continuity of care. You need to ensure that stories don't get told again and again and again. You need very good structures. That's an incredible effort on state-funded medicine. State-funded medicine doesn't want to waste any money. Now I'm moving to my mother tongue, to Germany. In Germany, complementary and alternative medicines have a century-old foothold since the Romantic era, where we were not happy with industrialization, and we're still not happy with it. With some, and recent studies looked at why is complementary medicine so strong in Germany. One finding was because German doctors don't have any communication training. It's paternalistic, not listening, etc. So it's much better to go to alternative healers who may be quacks, maybe not, maybe they are intuitive healers, but how do you know? How do you differentiate the wheat from the quack chaff? That's very, very difficult. You need excellent research with a long, long observation period and some good observation, good data for it. So I came to the conclusion it's a big, big mess. Of course,
Oh.
wounded healers who can connect to the patients have the time and are supported within state-funded medicine can do really a lot, but it needs to be over a long period of time. And as a street-level bureaucrat, I haven't changed. I savor the moments where I can spend time with the patients, the silence, which allows us to connect, the compassion. Touch is always helpful, but I'm less convinced that there's one method of Reiki or acupuncture or asking extremely clever questions that will be the savior for everything.
No, I talking about quacked. You know, I'm sure everybody is familiar with Ted Kaptchuk's work,
Yeah.
where he was one of the first few Chinese medicine practitioner who went to study in China, came back and was practicing. He's a Jewish boy from Brooklyn, and he was practicing in Brooklyn in the early 70s, and he was chased out of New York because he was considered as a quack. And look where he is now. He's a professor at Harvard University. Now go figure. So he's not so much of a quack. He's done a lot of work on the placebo effect.
I
Brilliant.
trained with anthroposophen in a lot of rituals, and I think that's very important and it's
Yes.
neglected. So I would say I had quack training, and I'm really happy about my quack training.
Okay. Thank you. That's brilliant. So, oh, where did it go? Steve,
Oh, yeah. I was just going
wanted
to
to say
agree with
something.
Jens. I was involved with the sign guidelines on chronic pain in 2013, and we're just redoing them, and the evidence is not any better for all
Oh,
the conventional treatments. It's really, really disappointing to look at the quality of the evidence, the smallness of the differences, and you see it every day in the pain clinic when patients come having tried everything, and they say, "I've still got my pain," or it's just taking the edge off. And so, yeah, I would definitely think that it's a failure of research methods rather than, that the evidence-based medicine has been a triumph where we're not looking at what actually matters to people. It's very much system-based research rather than the people with pain or the people with any sort of condition-based type of research. I heard a great one from a GP who was attending. We were trying to interest GPs in pain management in Highland, and this GP came out with a great one, which was the less evidence there is, the more heated the emotions are. And
yeah.
so I think that's where we are with pain. It's just such a mess. I would agree with you, Jens. It's terrible. The other story I had trying to interest GPs in pain. I once had a GP I'm coming up for retiring very soon. So once in the last 30 odd years of doing pain clinics, I once had a GP come and sit in the pain clinic. I said to him at the end of the day, I've got 3/4 of an hour with the patient. You've only got 15 minutes. And he said, yeah, but I might see them for 15 minutes 4 or 5 times a year, and that all adds up, and I know where they live, and I know who their family are, and I've seen them over the years. And I thought, I never thought of it that way. But like you were saying about the repeated going over the story, the same story, having to tell the story again, I think that's often a problem with the way the medicine works, is we don't have that continuity, especially with the way general practice works now. So yeah, how do we fix the research to actually gain more evidence from people?
I mean, I think,
I
yeah,
don't know. I think more fundamental is how do we teach the next present generation of new medical students to, I think, first of all, it's so important to connect with yourself, to know what is like, excuse my language, to know what shit you're dealing with. Because if you don't know what is going on with you, with yourself, you go into work, you're confronted with so many problems, so many patients wanting your attention. I think eventually it becomes like a mouse on a wheel. But if
yeah,
you can say to yourself, okay, let's take a deep breath in, take a pause before I go in to see the next patient. Now, this doesn't take 10 minutes, this takes less than a second in between patients. Take a pause, clear my head, clear my emotions, go in afresh with a new patient. Is that achievable or not?
I think so. Definitely. Manfred, you wanted to say something?
Yeah, thank you very much for this presentation. I have a question. Do you see a difference in the acceptance between men and women in your therapy? And would you repeat your study with chronic pelvic pain in men, for example, chronic prostatitis? And if yes, you can rewrite your book, Chronic Pelvic Pain in Men and Women.
I don't think it is, in my experience, okay? I want to qualify that. In my experience, treating men and women in NYU Cancer Institute, St. Vincent's Comprehensive Cancer Center, and mostly women in the pelvic pain and some men in the pain and palliative in Western General Hospital, it is not, I think, decided by gender. It is very much decided by how you've been, what your belief system is, and your own past experience with doctors, with different therapies. I think these are more important than gender. And of course, if I'm given money to study pelvic pain on men, I'm happy to do it.
Yeah.
Just tell me where to get the money. Because I think there's a great need too. A pelvic pain in men.
Yeah. Sarah.
I think just alluding to your question, where do you get the money? I will expunge my very depressing meeting today with one of our directorate leads when I was told in a letter that clinical hypnosis was not funded on the NHS and therefore was not to be seen part of my job plan. And I was pushing back on this, and basically the message was anything you do on this is not something that we're going to be paying for. And as I remonstrated about the need for service developments and integrative care being I think essential within oncology, the response was, well, we all do over and above, and you just have to apply for funding, outside your day job. And, so then if you can bring the funds in, maybe we'll have a right to change. But it seems to me that, the openness to change and integrating what we already know
It's not
in
that.
an evidence base is something that is the hardest tackle, because it's all about talking to your colleagues and winning hearts and minds literally within. And Kate might have something to say on that, because her hand's gone up, because it sounds like you're doing a PhD on that very thing. But how we talk to people who are beleaguered, burnt out, and really on the edge of being able to cope with the day job is part of the problem. And I think the real tragedy is that if we could integrate some of these things, which, as I say, is all about patient empowerment, trying to get the patients to look after themselves in a better way with the strategies that you can teach them in these sorts of integrative setups, then it would actually help the whole organization and the workforce.
Sarah, that's why I am going to, I'm building this website, and I'm going to have a Nourishing Life, Nurturing Self salon. And I think we all need it. You know, if you know how to take care of yourself in an appropriate way, whether you are a patient or a practitioner or a non-healthcare professional, I think we need that. If you can take care of yourself, you are in a much better position to deal with other problems.
Absolutely, I totally agree. Yeah.
I think Kate wants
So I
to
hope you all come to my Nourishing and Nurturing Life salon.
book us in.
Be there. We'll be there with you.
Absolutely.
I mean, one of the things I was just going to say, which has come out of my research, is that, and I think this is sort of where this thing of funding. So I interviewed a doctor, a consultant, lung cancer consultant in a hospital that I can't name, about a study that she had done using yoga for people with lung cancer, as a prehab and post lung ablation therapy. And I asked her why she wanted to do this study, and she'd managed to get some money, you know, she'd found some money down the back of the sofa to do this study. I don't know how she got it, actually. You know, it was one of those things, there was just some money left over and she used it to do this small study. And she practices yoga herself for her own well-being and health, and the breathing was particularly helpful to her. So that's why she thought it would be helpful for her patients, and it was. And we're talking about people who were from the back streets of a very deprived city, who'd never done anything like this before, who'd never had the opportunity to do anything before because they haven't got 15 quid for a yoga class or whatever. Fantastic outcomes. When she then went back to her bosses at the next level up to say, here are my results, which she had published. I'd like to bring this into our services because look how effective it is. Here's the quant data, here's the qual data. She was told that there isn't enough evidence. They just have to stick with pulmonary rehab and prehab, which they don't go to. They don't want to go to a gym. They're not doing it. So I mean, you know, the structures of power are incredibly strong. And it's this thing of, you know, this is how it's always been done. We've got this whole profession, physiotherapy, set up to see these people. We're not going to change it. So it's not, you know, it is very, very difficult to change things. But one thing
I have the same kind of experience. So
Yeah.
it's very difficult. And I've been spending like a long time in my professional career to try and change something. But I did change something in NYU and in New York. I got the Chinese medicine school to have acupuncture clinic. I was the first person. I got the Swedish Institute massage to go into St. Vincent's Comprehensive Cancer Center to provide massage. So I got Reiki practitioners from my little pot of money that I have. So I did make some changes in New York, but I find it much more difficult nut to crack here.
But I think the thing is, though, what you'll just to go on from that is going outside the system. So what I found in my research was that secondary care, so I'm looking at respiratory, and oncology, lung disease, so malignant disease and non-malignant lung disease, secondary care is non-starter. Okay, there isn't the money, it's not going to happen. But there is evidence of real change at community third sector level, and also there is access through palliative care. So we're talking about third sector and social prescribing and these other ways in. And that is where what we call morphogenesis and critical realist work, which is my approach, this is where change is happening. And it's been accelerated by the pandemic. So there's evidence that the pandemic has shifted how people feel about these kind of things, because there was a total lack of resource. People started doing things that they never thought they'd do before. They were doing yoga online, they were meditating, they were doing deep breathing, they were, you know, using acupressure to cope with their panic attacks. So I suppose what I'm trying to say is, for me anyway, my work, I have accepted that there is a block at a particular point and that you go round it. Does that make sense?
Yeah.
Sure.
Find another way.
Yeah, which is what you're doing with your, you know, and And so for me, it's about providing things free at the point of access for the patient. And there is so much going on, and it's sort of, you know, and I think things will change. And just from my interviews with quite powerful people, I managed to speak to some people, you know, quite high up in, you know, there is evidence, qualitative evidence, that people's thinking is shifting, and younger doctors coming up. So I interviewed registrars and younger doctors who are meditating every day before they go into work, who are using breathing techniques with patients. It's just that they feel a little bit embarrassed doing it still because it's not quite in their job description.
Yeah.
Well, you know, I think it's absolutely key that we've already identified trying to get the younger, you know, trainees aware of this, and the integrative and the lifestyle medicine movements are really coming on a pace now, actually. But I think what we do need to do is just to keep joined up in terms of, you know, the people who are enthusiastic about this, because, you know, it's not usually very many in one trust, perhaps, but by supporting each other, we can actually hopefully start to seed that enthusiasm
But
little by little.
yeah, I think medical school is still teaching, very much teaching evidence-based medicine. Nothing wrong with that. I gave a talk to second and third year newly qualified doctors about all these integrative medicine therapies. Halfway through, there was a big fight between, well, not big fight, a heated discussion between one group who is for therapies like Reiki, and the other group said, there's no evidence base, you can't use this. And one doctor said, well, I've seen it work with patients in the ward, and yes. So I thought, well, if my talk had created this kind of
Stir it up.
yeah, then I've achieved something.
That's always good. Mary, you wanted to say something?
I just was going back to Manfred's point about pelvic pain in men and women, and I was wondering about those people who deal with this on a more everyday basis than I do, because I only deal with this part up. I'm a psychotherapist, which is not true, because obviously the psychotherapist is the whole body. But I'm wondering, for those of you who deal with chronic pain on a more everyday basis, if you see sexual abuse as a important or significant component of women's chronic pain, pelvic pain, as opposed to men's. It would be my hypothesis that it would be much more a part of women's presentation than men's, but I don't know. So I'm kind of just asking those who deal with this more than me. Is that what you see?
I can't speak about the men, but women certainly, I don't know what the percentage is, but certainly some women would have been abused.
I think it's 1 in
More
6
so than with
as
men?
well.
I don't know, because
I think it's very common in men as well. Yeah.
Is it?
Okay.
I think chronic pain in general is, and usually there's an early trauma environment, you know, with like things all over pain, maybe not just pelvic pain, but
yeah, that was just my question, really.
yeah, no,
Thank
it's
you.
interesting. Yeah, it's interesting.
I have a question. I'm very curious as to what you guys think about using Gebser's theory, different levels of consciousness, to talk about different therapies, how we are accessing different level of consciousness. It doesn't have to be evidence-based, as long as the therapies are safe and effective.
Speaking of psychotherapy, I think a lot of those levels are accessed in my work with people, but it would be very hard to say that's what I'm doing there, that's what I'm doing there. I have a colleague, we call her the child whisperer. She's brilliant at connecting with non-verbal autistic children and teenagers, and she is incredible. And I, you know, not that you could necessarily pass out those different levels of consciousness, but I know for sure that she's connecting at multiple of those levels
Yes,
in what
well,
she does in reaching these kids.
Of course, it doesn't have to be clearly delineated that this is magical I'm doing, this is archaic I'm doing. Because when you're working, like when I do acupuncture and I'm kneeling and I'm taking the patient's pulse, I'm talking with them, and that I'm accessing many different levels all at one go. I'm actually using the integral consciousness.
Yeah. Polly, you wanted to say something? You have to unmute yourself. There you go.
I couldn't work out what to press. I think patients are much more instinctive about accessing different levels of themselves than we are as trained doctors, where we've been trained that there's a right and a wrong. And I think it's really difficult to, well, it's that uncertainty thing, isn't it? It's very hard to step into the brown squidgy bit in the middle. We're taught that there's black and white, and hopefully that's changing. In Wales, they've now got a new medical school that is bringing many more students into general practice early on, and I think hopefully they'll see that sort of engagement with patients. But I know an English medical school who we used to take students from were reducing their contact with primary care. And I think when you put people into high-powered secondary care situations, they're not going to learn that as well. But I think patients, and I mean, this is a self-selected group, isn't it, here? But we all instinctively know that it's not just about a right and a wrong and a cabinet. And I think patients know that and see the falseness of the sort of the medical model, and that's partly where there's no trust in it.
Yeah, good point. Steve, you wanted to come back?
Yeah, I think that you see that primacy of the cognitive bit, the consciousness and our rationality, like the Ian McGilchrist's left brain, right brain conflict that goes on is a large part of the problem. And the most difficult patients and the most unlikely you're ever to make any progress is where you're having to have some sort of confrontation about the the sort of rational reason for pain or pathology, and so on. So and if you think about it, we're all evolved over billions of years from single-celled organisms, and we've evolved all these processes and ways of sensing which we've very little understanding of still. I think it's a fascinating
absolutely
area.
Peter, want to come in on that?
Yes, can you hear me? I can't access the bottom of my screen, so
don't worry.
I can't. The patients who come to chronic pain clinics, most of them have, because they've been in pain for about 5, 6, 7, 10 years or something. They have tried everything, and nothing seems to work. And I think we possibly need to read in the context of this evening's talk. We need to decide to explain to patients a slightly different definition of working, and what patients mean by working is that they actually reduce the sensation of. The therapies they've had in the past have failed to reduce the sensation of pain, and I think it possibly I think if I've understood correctly, the aims of the sort of thing we've been talking about tonight are slightly different, and I think this needs to be explained very carefully to a patient if we're going to introduce them.
Yeah, I'd just like to say a couple of things about that. In clinical hypnosis, you can use hypnosis for chronic pain, and it's quite interesting when you ask the patient afterwards, has the number gone down, you know, from 0 to 10 or whatever how we ever measure pain. Sometimes they'll say, no, it's still an 8 or a 7, but it's not so bothersome, because in the definition of pain, there's a physical thing and there's an emotional dimension to it. And it seems to be that if you can reduce the emotional response to the pain, the suffering gets less. It's not so bothersome. But the other point I'd like to make is, I don't think it really matters how much evidence base you come up with for acupuncture or hypnosis or any of that stuff, they will still not believe you. It doesn't matter how many RCTs you present, they'll still say, nah, don't believe it. That's been my bitter experience. Anyway, Tim, we're nearly out of time.
Who will not believe you, Maureen? The patients?
Those other horrible people that I won't name. But of course, managers who don't know anything about clinical medicine will reject things out of hand through sheer prejudice.
Well, of course, yeah. I mean, just to go back to what Polly, I think, was hinting around, or if I understood her correctly, was perhaps driving at. The elephant in the room in many ways is the fact that patient autonomy, patient agency is crucial in any kind of successful self-management. And it doesn't matter what bag of tricks the patient comes to you with, or what enlightened whole body philosophies you bring to your consultations. If you are still fixed on the model of you, the expert, mending me, the broken patient, then it's never going to work, or it's certainly never going to work from my perspective, because the only component that I've found useful in any amount of a lifetime search for not for a cure, not to be fixed, but just to manage pain successfully, has been the penny drop moment that I had to forget seeking wisdom and guidance elsewhere, and take responsibility myself and go to you guys for advice. There was the horrible thing in the Times about 2 or 3 months ago where all this rumbling on from the NICE guidelines, saying that, GPs were now going to be prohibited from prescribing any kind of pain medication. And instead they were going to prescribe, and that was the word in the headline, prescribe yoga and art classes and music lessons. My goodness, that word prescribe is what's doing most harm to all the good that all these approaches and alternative therapies could bring.
They try to manage it out of existence, don't they? Try to mess it up. Anyway, that's been fantastic. Has anybody got anything else amazing to contribute? Otherwise, I'm going to have to pull the plug. No?
Can I just finish?
Oh, go on, Kate.
Oh, sorry, I just want to share, because I'm sort of excited. I just want everyone, you feel like you've got I'm learning so much, and I'm just telling you the things that might be useful. Okay, so I'm reading you a thing from some of you might know. Have you heard of the Noi group in Australia? They really check them out. Yeah.
Okay. How do you spell it?
How do you spell it?
It's N-O-I. I'll send the information to Maureen. That's it. Just if you look up Noi and then pain in Google, you'll get hold of them. There are a load of Australian sort of physio neuroscientisty type people, and I have found that. So I wrote to Dave Butler, who's one of the originators of this, and I said, can I translate this to breathlessness? Because I'm looking at breathlessness. Because it's that you could change the word pain for breathlessness, okay, in all of this. And he sent me this lovely email back. He basically said, mindfulness, CBT, most exercise therapies, most rehab strategies are essentially behavioral strategies, i.e. change what you see in front of you with a healthy dose of motivational strategies. Nothing wrong with this, of course, but behaviorism has long been abandoned by educational psychology and some psychology areas for constructivism. Can we work with the patient to construct a new narrative for this person, one that allows them to self-regulate, problem solve, extrapolate, understand the power of context and all of this stuff, and flourish, essentially? And it takes us into the world of adult conceptual change. So I know that sounds like a load of hot air, but can you see the shift?
Yeah. Same thing. Brilliant. No, definitely check them out. So NOI, Australia.
They're Australian, and it's really simple. Patients love it. I use it all the time. And acceptance and commitment therapy, but that's for another day.
Sarah, you want to
Can
say?
I just, well, I know time is going on, but really, thank you for that, Kate. And from the point of view of what I've been learning about the sort of integrative oncology pathway, and I'm actually learning from our patients, you know, because actually the best therapeutic relationships are very much two-way, you know, that you actually feel better for having seen your patient and been able to help them in some way. And that may not be as a radical, you know, life transforming help, but actually that personal connection often makes people feel better if you got it right.
Yes.
And I think that you know, we are so hell bent on the protocol driven management pathway. And of course, we know that there's never one size fits all. Human beings are not one size and are by nature absolutely inhomogeneous all the way through us, you know, and actually the trouble is that this individualization of therapy is what the integrative sector is all about. And actually a core element to that is the patient choosing what they want to do when they want to do it, because not everybody is in a place to be able to adopt radical change. And often it is really a question of education and the power of education that we know even understanding how your pain is derived seems to bring the pain score down. I mean, go figure. So actually you haven't changed anything else except a few neuronal connections in somebody's head. So actually, that is where I feel that the time and where the digital side can really help us, because it's bringing us to, you know, new knowledge from so many diverse realms. If we can put that into the patient's domain, you know, then actually we've done a small component of just empowering them to find what suits them. And actually, it's obviously where we can sort of choose what the evidence base is, and it's not just a random here are a bunch of snake oil purveyors. Of course not. No, it's got to be educated and triaged, if you like.
And it's got to be bespoke for the individual patient.
But bespoke, and they will hopefully find something that helps them, you know, along that route that you want to help with. You know.
Brilliant. Yeah, thanks. It's all good stuff. Thank you, everybody. That's been fantastic. I'm going to have to pull the plug on you now. Oh, one little thing. Does anybody mind if this recording can be sent on to the Pain Society? They asked me, and I thought, well, I can't because people's consent hasn't been granted. But has anybody got any major objections? Their little videos, nobody cares really, do they? Anyway, I will assume I'm sure it'll be fine. Anyway, they might not want it, but that was a question.
Yeah.
Anyway, brilliant. Oh, and the other thing is Rydal Hall coming up next June, July. So we'd love to see everybody there. We're compiling the program, and Ooi-Thye has kindly agreed to give a talk. So it's going to be amazing. So yeah, everybody is welcome, and I will be sending out the blurb ASAP. Okay, team. Thank you.
Can you share the link with us as well? Oh, sorry, Maureen.